Welcome to this evening's webinar. I'm Dr. Diane Tower, APMA Director of Clinical Affairs, and I'll be your moderator this evening. We are pleased to have Mr. Wayne Singer, Vice President of Regulatory Affairs at Dorina Solutions with us this evening to discuss the COVID-19 related hardship exception being offered by CMS for the 2020 MIPS performance year. Mr. Singer also provides white glove services related to MIPS to many of your APMA member colleagues. This live webinar will be recorded and is provided complimentary exclusively for APMA members. We will have time this evening to address questions, so if you have questions throughout, please type them in the questions box in the GoToWebinar toolbar. I will hand it over to Mr. Singer.
Thank you, Diane. Good evening to all, and on behalf of Dorina Solutions, we're very happy to be a part of this session. It's really our opportunity to share with you and bring everyone onto the same page as to take advantage of some of the burden reduction that CMS has offered for obviously the MIPS program for 2020 reporting year. What we'll do is go through the program and develop just a how-to process that would allow you to work with your current situation, adapt it to the process that's in place to allow for a hardship exemption, and then actually take you through what are the options that are available from a standpoint of what categories to opt out of, and then what are the situation, what's the let's say what would happen as a result of your MIPS status from a standpoint of where you would be positioned for scoring and or incentives. So that's our objectives today, and as Diane mentioned, feel free to put questions in the column, in the question answer area, and we'll get to as many as possible. And even if time runs out, we'll be able to follow up with you as a part of the follow-up to this session. So what we're going to do is actually concentrate on what CMS has offered for the COVID-related hardship exemption for MIPS performance year 2020. In June of this year, on the 29th, CMS announced that they were actually expanding their extreme and uncontrollable circumstances, the exception to include COVID. Last year, if we all remember in 2019, they kind of retroactively, automatically, you could say, put in an exception for people because it really hit everyone right during the MIPS submission process. So there was really nothing people really had to do. CMS was taking care of it. You could still do your submission if the pandemic didn't really, I guess, derail your efforts. But CMS was very relaxed as far as what people had to do to avoid a penalty. Now this year, they've actually taken steps to put a process in place, and that's what we're going to talk about here, is this ability for you and in a sense a mandatory action that you need to do to go out and really claim what form of exemption needed with regard to extreme and uncontrollable circumstances for COVID. Now, in the slides, and also you'll notice in the handout section, there's a fact sheet that they put out, which really is a pretty good detailed overview of what the extreme and uncontrollable circumstances is all about, and specifically how it would be related to COVID. What happens, obviously, when you do this opting out, there's a reweighting, and you can either go, if you're opting out of all the categories, you go to a 0, which means, a score of neutral, which would be no penalty, no incentives. However, what we want to do today is really give you an opportunity to really take advantage of some of the options within this to really even maximize your score and even your incentives. So they basically put this extreme and uncontrollable exception out there. You have until December 31st at 8 p.m. Eastern time to submit it. And then you also have options to look at what of all the 4 categories, there's quality, improvement activity, promoting interoperability, and cost. Of those categories, which one or all 4 do you need to opt out based on your circumstances? So what we're going to do here is really cover the process of how to go in and really apply for this exception, and then also talk about the implications of doing it, and then also, obviously cover any questions that you might have. So the basic, I guess, go-to area that CMS has put in place for MIPS basically since 2019, late 2018 and then all the way through 2019 and currently, is the QPP portal. That's the ultimate go-to place to check your eligibility, to check even after the fact for 2019. As you notice, you can go and look and get performance feedback. Also, what you can do is sign in and do this hardship exemption. So the process would be to go to the URL for the qpp.cms.gov portal. And then what you're going to notice is up here is a sign-in area. And those of you who have actual credentials to get into your specific portal address and a portal site, what happens when you hit that, you'll get to a area where you'll sign in with your username, password, and then also your agreement. What they've done is they've put in a sophisticated two-factor authentication, and when you hit submit here, that will come up and ask you to confirm that you're going to get a second factor of authentication that's going to come to either your email or your cell phone, whatever you've done when you've originally registered. And that will then get you into the actual portal. Now, for those of you who do not have a portal access at this point, you'll notice over here, there's the little register button. At this point, if you do not have access, what you'll do is click on that, and it'll take you to another area where you will be able to sign into what they call a HARP account. And this is the ability for you to sign into this portal. It's a very secure process. In fact, what they do when they take you through the initiation is they really want to prove you are who you say you are, and they'll take you through a identity proofing step where they are going to grab information from your credit report and just have you answer these questions to, again, prove you are who you say you are. And these will be high-level questions, like here, they'll be listing maybe 4 banks, and they'll ask you, have you had a car loan with any one of these banks? And you will obviously, that's information only you know. And then there's several other ones. Have you ever lived on a street? And they'll give you a given 4 street addresses. Which one is one that happens, streets that you have lived in or cities you've lived in. And they could include even none of them. So it's, again, these are questions that only you should know. When you're filling this out, obviously, sometimes if you defer to maybe an office manager or whatever, if they're signing in on your behalf, you would literally need to be there to be able to answer those questions. But this would then allow you to sign in and get access to the portal. And it's pretty much immediate. It's about depending on, going through the process, it's probably about a 20-minute exercise to fully load in the first time. But then even if you've had your portal access and you've forgotten the password, you can hit the standard forget password, and that reintroducing or re-upping into your portal is a very quick event. Now, we'll go back here and say, now let's say you have the address, your username, your password, you're into the portal. The first thing you're going to get to is this home page, and you'll notice on the left-hand side a navigation bar, and CMS is making it real user-friendly, and they have certain navigation within the middle. For the exception application, on the left-hand side, you'll see where you can click, and it'll take you there. Additionally, about halfway down, you'll see another tab. That's another way, another navigation capability that gets you into the same part for your exception application. So once you've logged in, you can do many other things. You can look for your feedback for 2019. There's several other elements. So this is that go-to portal for multiple elements within your practice, but specifically here, this will allow you to then get to the application portion. Now, once you're there, and you've clicked either that middle button or that tab on the left, you get to this screen, which is where you start your application process. So you'll notice down here, it basically says you're going to add an application. And this could be multiple use if you're in a practice and you've got multiple practitioners and each one are going it alone and you want to have an exception on your own. If you're as a group, you can do it just once, but here's your ability to then click and you'll go into the application process. So what will happen first is they'll have a selection. Do you want to make an exception for just promoting interoperability? Now, this is a carryover from years gone by where if your EHR is you're not using an EHR properly from a 2015 edition certification, where you're a small practice, they gave you these reasons that you could exempt out of just promoting interoperability. But for the purposes of this presentation, we're going to focus on doing the extreme and uncontrollable circumstances exception. And don't worry that it's not talking about specifically COVID here in the language. We'll get to that shortly. Again, this has been in place since the 2017 initiation of MIPS, and it really was initiated for those areas like are going on currently where there's fires like in the far western states, the hurricanes that I think are coming on board in the Louisiana area as we're speaking here. It was really meant for those practices that were under FEMA disaster area and needed relief. But again, they've expanded that to this COVID area. So you will select this button. What will happen is another screen will pop up that asks you to choose, are you going to submit as an individual? And then in that case, you'll go and add the NPI for your particular practice, or you would select the group button. And in this case, they're going to ask you to then fill in the TIN. That's the way that this process will now identify and link this submission to your particular situation. What will come up next is this actual form that you will fill out. I've kind of covered up, just an entity here, but it'll be your practice, either group name or individual name. They'll repeat it here from an NPI, and again, your name. There will be a drop down that is automated in a sense. When you drop down, it'll have your practice that's affiliated with the TIN or the NPI identified here, and select that. And that way, again, you're now confirming that they have and know who you are. You've also submitted the right TIN or the right NPI. It's kind of a nice check and balance. One of the other elements here is when it says who is filling this out. When you get to this drop down, you'll see it's a clinician. That's if obviously it's the provider filling this out, or you can have clinician staff. So you can have someone within your group fill this out for you or on your behalf, and then make sure you're going to put in the email that you want the information to come back to, because almost immediately when you submit this form, you'll get an email acknowledgement that the form has been submitted. And then almost, in fact, CMS is ramping up their methodology, and almost within the same day, I am seeing that people are getting an approval email, or sometimes even within that QPP portal, once you finished out this process, they have an approved right by your name. So again, watch it closely, make sure this is the email that will give you the acknowledgement as well as the follow-up when you're approved. All of that should be, let's say printed out or digitally saved as your, what I would call, book of evidence. This is saying that this year you're approved for these types of exceptions. And if ever there's a question 2 years down the road when, the 2020 performance year gets into the 2022 payment year, 2 years later, it can't, the information gets foggy unless you keep it in a known position, known place that you could retrieve it on demand. Once you've filled out this section, you'll see and be able to scroll down to the actual extreme and uncontrollable circumstances details. You're going to want to do the COVID. Again, some people on here might also be in those affected fire and or hurricane or other natural disasters. You can choose any one of these. You do not have to choose more than one, but any one of them would continue in the same process. But let's focus on the COVID element. Now, they'll ask you the dates that this has affected you. Typically, most people are saying right around the March of 2020 is when it really, the pandemic really started causing the whole practices to close down or diminish in their ability to see patients. And then you will hit that it still persists, the event still persists. Obviously, sadly, we're still under the pandemic situations, and depending on where you are in the country, we all have different variants of severity. So it's not an end date, you just say it still persists. Then the key area here is the documentation more verbally or in a written format here as to why is there a need for you to have this exception? Now, I've put in the verbiage, which is really what they're looking for here. And I have a my or our, depending on, is this an individual or a group submission? But the practice has been severely impacted by COVID-19 crisis. And as a result, the practice is unable to successfully document MIPS related data and measures for this performance year. That's as simple and succinct as you need to be. No long paragraphs and multiple pages. No other documentation is needed to be submitted, meaning you not have to show revenue loss or patient scheduling. Those things could be what you keep in a book of evidence. If ever audited, we'll see if this ever gets to that. But that could be your calendar, how it showed March, April of this year versus March, April last year, or just everyone has different ways that you can present how you've been affected from the COVID situation. Next, they're going to ask, what categories do you want to exempt out of? And for this, and we'll show you why, you can exempt out of all 4 without having that absolute end all and you can't recover from it. We'll show you how choosing either quality and cost, or in a sense, what I'm recommending is that you select all 4, and I'll show you how we can use and leverage what CMS has done to reduce and allow for burden reduction for you as a provider to, in a sense, work within this system. Then, very important, as you finish this form over here, this will turn to blue and you make sure to hit submit. And that would basically submit the application. You would most likely get an email to the email that you had registered immediately acknowledging receipt. And like I say, it's been going lately, approval has come also almost immediately. Now, what I'm showing here is the result of what you would do for opting out. What I mentioned that you would opt out of, all four categories, that would take you to neutral or no penalty and no incentives. Now, what we're going to work through here is, what if then you can, and we'll show you the documentation that says, actually, now we can remobilize here and use the last quarter of this year, that any 90 days, as they call it, so October 1st through December 31st, to actually be able to submit 2 of the categories. In this case, improvement activity and promoting interoperability. What will happen with an improved exception is that they will reweight what, you can see if nothing were to be exempted, quality was 45, cost is 15, improvement 15, and then promoting interoperability was 25%. By choosing this option, these get reweighted to 0 or to get attributed to 0, and then reweighted over to what was 25 is now 85. The cost and the quality points are reweighted over to promoting interoperability. So you now see where the heavy lifting is now gone to 2 categories that are really relatively in your control. It's 90 days, it's using your EHR, and then as we've talked with improvement activities, pulling from some of the activities that are, again, relatively low bars from a standpoint of historically, like one of the improvement activities is showing that you have 24/7 access to your EHR. And sadly, I'm sure on there you're all saying, yep, we do that. Additionally, another one, if you're a larger group and you need to have more than one improvement activity, there is one that's out there now for using telehealth. Or as you're allowing people to see information or get access to the portal, there's another improvement activity that you can use to maximize this category. And then promoting interoperability, we'll talk to shortly. The other thing is, if your situation is that, you say, I really have had a hard time just doing the quality measures. I did not have a full year of documentation, and essentially that's the one I want to opt out of. Cost is something CMS does by itself, and if you don't meet the case minimums of the cost measures, then CMS will reweight that for you. So if you look at this option, again, quality will be reweighted into promoting interoperability. That gives you 70 points. Here, maximizing improvement activities, you're now at 85, which we'll cover and show you how that becomes the exceptional performance level. Cost would be something CMS rolls in, and then exceptional performance bonus, that's another thing that CMS provides, would give all upside potential. So you see, we're opting out of all four, but when we report and the actual restructuring takes place, you're in a position to score 100% in MIPS. Now, here's what you would really need to do when you are now saying, okay, I'm going to opt out of the quality part. Cost is not something you have worked with, CMS takes care of that. And if you've opted out of it, that would be reweighted into the promoting interoperability. So what you will do is improvement activity. Again, there is a need to get 40 points to maximize the category, which carries 15 of the composite points within improvement activities. So if you're a smaller group or individual that's 15 providers or less, if you do one high weighted, like this 24/7 access to your EHR, that gives you 20 points, and then CMS doubles it to 40, and that would maximize the improvement activity category. If you're a larger group, 15 or larger, or over 15, then you would need to either find two 20-point improvement activities, or you would have to combine in any of the math, the 10 points for medium, so 4 mediums, and you can do 120 and 2 mediums, but that's how you would maximize the improvement activity. For promoting interoperability, there's the two categories are a must do or you will not get any score. The first one is the security risk analysis. And as you know, if you need any assistance on that, at the end, we'll give you how to get a hold of myself or Richard at APMA. There is a CMS security risk analysis, very well done, very robust from a standpoint of covering all the bases needed to look at your practice as it turns to, the HIPAA or security related vulnerability. And oh, by the way, it serves as a security risk analysis. It's promoted by CMS. It's free. You don't have to pay a third party to come in and do it. And if ever audited and you produce this particular security risk analysis, how can you go wrong? It's the CMS promoted risk analysis. It's not a homegrown or something you might get have scrutiny. It's the one CMS has put out there, and that's on its about 4th or 5th iteration. Then you would actually do e-prescribing. Either it's your standard numerator denominator, how many prescriptions you have written versus how many went out electronically. The EHR should take care of that for you. If you do fewer than 190 days, you can exempt out of that. And then those points will be re-weighted to the next one down, which is send or receive a CCD electronically. And that's how you would exchange referrals from primary care to you, or if you're admitting patients to the hospital, or you're referring them to other individuals. Again, if you're not doing them in less than 100 in the 90-day period, you can exempt out of these two, and then they will then reweight down to this next one down to provide patient access. You can see that what this one is, it's a must-do category. This is providing access to the patient to their portal that is pretty much, in most cases, it's provided either directly through the EHR, or the EHR is arranged through a third party to allow this patient portal. Providing access is the key term. Typically, if you have an email on file in their demographics, the EHR will take care of an automatic invite to the portal. The patient does not have to log in. Obviously, CMS and everyone is hoping that patient engagement is key. However, it's your action to invite them that increases the numerator. And these are for unique patients that you see in this 90-day period. So if you see, 500 patients, and really 300 are unique, the others are coming back for follow-ups, it's those 300 that are the denominator, and how many have you invited. And using the automated process of your EHR will take advantage of maximizing this to make the numerator as close to the denominator as possible, because that will carry the weight, especially if you've reweighted any of these above, or this above and then below the public health, reweighting into this. That's going to carry the day for this promoting interoperability score. And that brings us to the last of the measures. There's 5 options for public health. Your scope of practice, such that you don't administer immunizations, you're not reporting outbreaks of these things that are trigger events, flu, obviously COVID now, any of these conditions, measles, the child ailments. Your scope of practice is not in the mode of reporting on those, so you can exempt out of immunization, syndromic surveillance, and basically cover the public health category. Those points will also reweight up into the patient access. So again, that's why maximizing that, taking advantage of what your EHR should be doing in an automated or very close to automated fashion for you, will allow you to maximize the promoting interoperability. Again, going back to the must do, the security risk analysis could have been done anytime this year from January 1 to December 31st at, let's say, 11:59. But that has to be done. It does not have to be done just through the October through December 31st. Obviously, if you haven't done it, now's a good time to gear up and get that ready. So what happens is, again, we're leveraging CMS's, I guess you could say, burden reduction or their understanding of the situation. What this is telling you here is if you opt out of all 4 categories and get approved, however, you find a way that, again, to remobilize the last quarter of the year to actually submit the improvement activity and promoting interoperability data, then what will happen is CMS will maintain the exemption for the quality and costs that were approved and will allow the reinstallation, so to speak, of the 15 points that the improvement activity is worth, and the reweighting of the 2 categories of quality and cost will be added to the 25 points of the improvement of the promoting interoperability, and you'll then have that opportunity to maximize 85 points with 1 category and take you over the top with the improvement activity on following up with, again, that relatively low threshold of effort to document that you have 24/7 access, you're using telemedicine, you've provided, in promoting interoperability, you're providing people access to the portal. So one of the improvement activities says that you're using the portal to communicate with the patients in whatever form or fashion. So we're really putting together a story to leverage what CMS is allowing and also trying to reduce the burden to as low as possible. Now let's look at what this means from a incentives and or scoring. So if we look at what we're doing is we're taking quality from to zero from 45. We're taking cost to 0 from 15. And then by reporting in the last quarter, any continuous 90 days on improvement activities, we're maintaining the 15. Then we're also going to be using the reweighting of from a quality and cost, and you see how it then makes it PI worth 85 points. And from this standpoint, at 85, if you look on the left-hand side here, any of the 85 plus is what's called an exceptional performer. Now, if you're looking at the way CMS has structured it, if you get a 0 to the 1125, that's an automatic 9% penalty, or what they call payment adjustment. It's going to be negative 9%. If you're in between the 11.26 to 44.99, there is where CMS has discretion, and you will have basically a reduced negative, but you still be in the negative. At 45, that's when you start at that 0 or neutral area where you're going to have 0 incentive and 0 penalty. Now, this area here, what we're looking at is where this is the budget neutral side of MIPS, where it's saying those people who have 45.01 to 84.99, that incentive dollars, there's a percentage, but the dollars will be based on the people who fail in MIPS, kind of this side of the equation, goes to paying whatever incentive that will come out of people in this budget neutral area, that first level of incentives. Because the opting out is relatively easy again this year, that bucket of payment from those who fail could be relatively low, just like what happened in 2019. So from this standpoint, working hard to get to the 45 to 85, just under 85, is probably not going to have a big bucket of incentive dollars to work with. But that's why we want to focus on this next level, the 85 plus. That's where CMS has $500 million that allows them to pay the incentive to those folks who are exceptional performers. Those dollars aren't going away. They're not going to be pulled away by Congress or whatever. That bucket is there. And I guess I'm looking at the option or the potential where, since a lot of people might say, well, let's just opt out completely and I will be happy with my neutral value, then those who not only got into this area, whatever incentive there is, but all the way to the exceptional performance could be reduced. That's just after watching this program since way before, we've been involved in this since meaningful use started in the 2011 arena, and PQRI, PQRS, the first several years of MIPS, just kind of having a feel for what people are doing. There is somewhat of a MIPS fatigue. I probably hear a lot of, could virtually see a lot of heads going up and down. And so this would allow you to be in a category of exceptional performers where my impression is that bucket it was 500 million will then be distributed amongst fewer candidates. That's where doing this, reducing the burden, focusing on improvement activities and PI, just the last 90 days of the year, also taking advantage of what CMS is doing for reweighting, puts you in a position to really be incentivized by the MIPS program, which is what it's been trying to do for as many years as it's been in place. So that's, again, why we're saying do the exemption for all four, but the last 90 days, take advantage of your EHR, meaning what parameters they have in place. If you're e-prescribing more than 100, which I think the majority might, falls into, just do your normal e-prescriptions. There's no extra work. Whatever is clinically indicated, you're prescribing. But it would be good to, let's say, mid-October timeframe, to go and run a MIPS report within your EHR to see that it is indeed capturing your efforts, not only with the e-prescribing, but the fact that you're doing your staff or yourself are doing the granting access, or sending out email access to that, just to see how you're doing, so that in December you're not scrambling to see why it didn't happen, or even worse, when the submission time opens up between January 2nd and March 31st, you're not going back and trying to retroactively fit things in. So that's just a good sanity check to keep an eye on, see that the EHR is working as indicated, and if not, you can work with them to bring it up to speed. Now, as an example of this effort, if we look at, again, the eligibility starts at $90,000 of Medicare Part B reimbursement. Just for rounding out here, I'm starting at 100,000. And basically this would be an individual, or if you're a group and somehow you wanted to add together, but this minimally the threshold is 100,000. If you do nothing, it's an automatic 9% penalty. That's a $9,000 ding to your reimbursement that begins in 2022. That would be on every EOB. They would be reducing 9%, and if it's based on $100,000, that would add up to a $9,000 reduction. And again, if you look at, these are looking at 2020 numbers. If we're saying America's getting older and Medicare getting more significant, that what dollar value you looked at this year might be at least the same, if not increased. And so it's 9% of that 2022 dollar value that we're looking at here. However, let's look at the positive side. An 85 plus gets you into the 0.5% to 10% range. Now, 10%, I do believe, even in the 8, 9, 10 is probably something historically CMS has not seen, and I don't want to have you leave with the impression that doing this is going to be an automatic, 9 or 10%. Realistically, though, again, it's a minimum of a 0.5%, but realistically, again, with this reduced amount of people participating, again, in the single digits, 1 to 3%, that would not surprise me at all. But that's why we're talking a range here. Doing nothing is a minus $9,000. a maxed out would be 10,000, but there's going to be something in the middle that would really have a good return on investment. And I hope what we're portraying here is that the burden on your side is pretty much as low as it can be. You're going to do your normally prescribing. You're going to have your staff invite those unique patients that are seen during the last 90 days of the year. And then during a security risk analysis, which if you've done one last year, you open it up, make sure it's current, change and add anything that's changed, sign it for this year, you're done. Or again, if you need to, the CMS version is about a 45-minute exercise, taking you through the complete range of things that are important to a practice. And again, what I've done with people when they go through this, they actually say, well, this is a pretty good thing that I should have done anyway. And then, oh, by the way, we're going to get credit for MIPS. I love to put it in that position. It's not a burden, it's a business benefit. And then also we're getting credit. And then that same security risk analysis will live again for next year because of the budget neutrality of MIPS, it's not going away. The 2021 proposed rule is about to hit they go from proposed to final pretty much the 1st of October. And so 2021 will be starting all over again, but that security risk analysis would have utilization for next year as well. Okay, so the key takeaways here are, if you review the fact sheet, just to see, again, get a good feel for how CMS has put this extreme and uncontrollable exception or circumstances exception into place. Determine what are your circumstances, and then make sure that you go through the process and fill out the form. If you do nothing this year, unless we put at the very beginning slide that this is the facts as of today, sometimes CMS comes out with what I call a just kidding, but as of right now, if you do nothing, then this year you would be into the -9% penalty. So you do have to go and revisit it and then do, from an exception standpoint, put in what pertains to you. There still is the promoting interoperability only, or as we're focusing on here, which again, universally, I've pretty much talked to lots of different providers in podiatry throughout the whole country, and COVID has universally caused people to alter their normal behavior. So it's not a far-fetched thing that says everyone's been affected. But then select the categories that you would opt out of. What we're recommending is all 4. It's kind of a hedging bets because you can then rally and come back and do the 2 we're talking about, promoting interoperability and improvement activities. Focus on those for the last quarter. It's again a burden reduction. I think with holidays and all of the 90 days of the last 3 months of the year, there's maybe without weekends and the holidays, maybe 25, 30 days it would seem that are really active working days. Again, focus on that, the burden's reduced, and then you would submit your data as you would normally for the promoting interoperability and improvement activities by March 31st, unless they extend it. Like they did last year, but by March 31st. And obviously, as part of our affiliation with APMA, we are the registry. Our MIPS score is a registry that not only will be used that you can move your data into to see how your score is accumulating from the October through December, but then we are also the the registry that allows you to submit through us right to CMS and kind of a one-stop shop. So that's kind of why we're presenting it here. It's all is not lost for MIPS. I guess what we've observed is because life is coming at us in multiple directions, MIPS tends to get on people's radar almost the end of the year or the last quarter. So what we're doing is taking advantage of what CMS has put into play, what we can do to maximize, in this case, not worry about, am I at just over 30 or just over 45? Actually, it's kind of a swinging for the fences and getting into the exceptional performance category. So that's what we're proposing through here. That's the elements. Some of the handouts are not only the fact sheet, but then these slides are in the handout. We've also the kind of a step-by-step or an understanding of what this exception is all about, what you need to do, what you have to do to get a HARP account if you don't have one, or signing into the QPP portal. So hopefully we're giving you the whole complete program of what to do and how to succeed in MIPS for 2020. All right, I think, Diane, we're ready for whatever questions there might be.
Yes, thank you so much, Wayne. We do have some time this evening for Q&A, and before we start with our first question, I'd also like to introduce APMA Registry Manager Richard Schwartz. Richard, thanks so much for joining us this evening.
Thank you, Diane. Thanks, Wayne. Nice job.
Great. Yep. Thank you.
Great. Now, Wayne, we have our first question here, and it reads as this. This provider is in a very small practice that has done the PI exemption the last 2 years to reweight to the quality category and have submitted improvement activities and have been successful in avoiding the penalty. Should this provider exempt all 4 categories this year or just PI so that they would get some or all points for quality and improvement activities?
Well, I guess it would also depend on what score you did achieve. That avoiding the penalty last year, a 30 did it. This year, it goes all the way up to 45. So I guess if all things have remained the same, I guess I would see what your score is, and that would avoid the penalty. If that's your strategy, then opting out if COVID has affected your practice and the quality. Remember, quality has to be for the full year, and that's why that one is really quality and cost are the full year, but quality is one that you control. That's why typically people have been in a restricted element of what patients you've seen, data or case minimums. You maybe have not been able to see all patients throughout the year, especially the March, April, May timeframe, maybe even longer. So I guess I would have to say what your situation would be. If it's avoiding the penalty just by getting over the 45, then opting out using the COVID exemption gets you the same objective without any more effort. However, if the reason you've opted out of PI is because maybe you don't have a 2015 edition EHR or you aren't using it to the full effectiveness, then again, opting out of more than just the PI category would probably be what I recommend. And again, remember, you have to do at least 2 categories or CMS will automatically give you a neutral. So again, if you opt out of PI, don't do improvement activity, but then just quality, that's a neutral as well. So I guess the path of least resistance would be opting out due to COVID, and you get that same neutrality. But reassess maybe if your EHR can handle the PI category and improvement activities, and you'll get back into the 85 plus.
Great, thank you, Wayne. And our next question is, when you mention the phrase unique patient, and I think this might be in reference to inviting unique patients, what do you mean by unique patient for data entry?
Okay, CMS, the rule for the provider to patient access, the denominator definition is those unique patients that you see during the reporting period. So what that means is the first time and only the first time you see them during the reporting period. Now, this could be a repeat patient that you've seen earlier in the year or years gone by, but it's the first time you see them between October 1st and December 31st, that puts them in the denominator. Now, if that same patient you saw on the first, an operative patient, and you say, I'm gonna follow up and see him in 2 weeks, that second visit doesn't count. Only the first time you're gonna see him between October 1st and December 31st. That's the denominator. And then did you provide access to their portal, the portal that's associated with your EHR, that puts them in the numerator. And you really would like to say, you know, again, get that as close to 100% as possible, because that will most likely carry the weight of the points within your promoting interoperability. So a unique patient is first time you see them throughout the 90-day period.
Okay, we don't have any more questions at this point in time, but I will ask you both, Wayne and Rich, for the folks who you've worked with regarding the HARP account, we do have some information, as Wayne mentioned in one of the handouts. There are some links to videos and document resources on how to get the HARP account. But we've heard from some of our members that it's a pretty intense or personal process. Can either of you comment on that?
Yeah, again, in taking people through it, it does have multiple steps. It does make you kind of go through that link to your Experian, credit report, where it really has questions in there that only you know. And again, so that in and of itself is just where you have to be present for whomever is filling it out on your behalf, unless they really know you. But that's really what I found, is that it just going through that identity proofing is what's taken most of the time. And then depending on their volume, how soon they reacting and come back with your credentials. Richard, is there anything from your side?
The only thing I want to add to that is that you only have to do it once, and once you do, you sign up for that HARP account, you can use it for multiple things within QPP. So it is a little bit burdensome just that one time, but it's a one-time thing, and then you're signed up for good.
Yeah, and that the QPP portal has become it used to be the quality and utilization report place to go now, or I mean, there was a separate area. Now it's all consolidated under there. You can see the performance feedback from not only last year, but it's quantitative or, additive from 2017, 18, 19. Obviously, once 2020 is done, somewhere in July or August of next year, you'll go there to see how you did in 2020. And again, it's a good solid, getting that access has multiple utilization, not just for this one-time application for an exception.
Great, thank you. And it looks like our conversation has sparked a few more questions. So is it true that you would get points for patients who would refuse portal access?
Okay, what that is that's called opting out. And if the key is that you're providing the opportunity, you're providing access to them, whether they want to do it or not is their choice. Again, in the years gone by, it used to, if you remember from VDT, View, Download, Transmit, it was something they also had to go there, and a significant number of people had to go there. CMS heard you loud and clear that what patients did after they left you in your office was not in your control. So by seeing the patient and providing access is all you need to do. If they opt out, it's their choice.
Thank you. And our next question is a two-part question. Wayne, if a provider opts out of all 4 categories, can they still report just quality and improvement activities? And if yes, what is the time period do they need to report for?
Okay, so quality is, again, January 1 through December 31st. And so that's that. And the other is any given 90 days. So you can do that. And basically, if we go back here, then there's a different reweighting structure. If you're saying that, again, you can see all the thing. If you're now going to say, I'm going to do, again, if you're going to opt out of cost or if you're going to let that stay. So you can see what happens here. What was that, Diane? It was quality and improvement activities?
If someone just wanted to, if they opted out of all 4, but then reported on quality and improvement activities.
Okay, good. So what they're saying is if you have quality, you say no cost and no promoting interoperability and improvement activities, what would happen is the 25 now is reweighted in this direction. And you still could be, again, it's whatever percent. This is if you maxed out quality, you'd get the 85 points and then 15 here. So you still could get into the 100. You could, even by quality alone, could be an exceptional performer. But this is a pretty interesting road to climb because they've changed the benchmarks for the quality measures. So you have to make sure that whatever you're reporting on, if you had a 50% or 60%, that score you got maybe of a 6 or a 7 might now be reduced down to a 5 or a 4 because of reweighting. It might have even topped out at 7. You just have to do the analysis. The MIPS score tool or application that we have as part of our relationship with APMA allows you to put those quality measures in place and see how you're doing, and it would be reflective against the most current benchmark. So it's it's again, it would be done. You would have an opportunity, but this says maxing out is an 85, and obviously maxing out this would give you the ability to be, again, make up whatever difference here, and then be in the 85 plus category. But that's how it would be reweighted.
Okay, and our next question, Wayne, goes back to the providing patient access to the portal. What if the patient already has access and comes in during those 90 days?
Then the EHR should have that as, in other words, when you provide access, the logic within the EHR should account for that. That's what EHR have done when they do the certification. There's a certain within and outside of the reporting period. So when you provide access, it's registered behind the scenes in the programmatic logic of the EHR, and as soon as you see them during that range that you're going to state as your reporting period, then that access will catch up to the unique visit and then increment the numerator. And that's why I'm saying that that's all well and good. That's what they have presented when they did their certification. So somewhere mid-October, after you've got some patients coming in, it's a good thing to run that report and see if it jives with your feeling of, okay, I've seen, again, through October, however many you see, let's say, 50, 60, 90. Some of you are saying that, oh, come on, I see that in 2 days. But whatever the number is, make sure that you've seen your denominator of the patients that you're seeing and is the numerator incrementing. But the logic should catch up for when you see it. If you go back to the days of meaningful use, if you remember demographics, certainly you have patients in your record that you've seen historically, but you didn't get credit for demographics until that patient showed up for a visit. You didn't have to enter them in again, the name, address, phone, but as soon as you saw them, the logic of the EHR caught up. That's what happens with the promoting or provider to patient access.
Okay, we're going to ask a question here about the CMS security risk analysis, and the question is, where is it located? Okay,
I will provide to Diane a link, and she'll be able to do it. But there's a web URL that we'll provide to you, and you click on it. It's a downloadable process. It's very very quick to download, and then it's a step-by-step process taking you through. So what we'll do, Diane, is I'll give you the URL that you can make available with these this information.
That's great. Thank you, Wayne. So for our attendees, you'll be getting an email tomorrow after you've attended this webinar to our webpage, and that webpage is apma.org/COVID-19 MIPS. And we'll be updating all of the information with the handouts from this evening, the recording from this evening, and we will add the link that Wayne will share about the CMS security risk analysis to that. So thank you, Wayne.
Sure.
We have 2 more questions, and we have just a few minutes left here, so we'll try to get through them. If you don't have an EHR that's certified 2015, is that why we need registries?
For the quality submission, typically. Now, again, you can submit the quality measures through claims, but again, if you look at the benchmarking, CMS gives the lowest point value for, sadly, for measures submitted through claims because they're not getting as robust data. So a 50% performance rate in a claim might get a 3, where a 50% in a registry might give you a 5. And that same 50% performance rate as an ECQM coming from an EHR with more robust data might be a 7, 8, 9, depends on what measure. So again, submitting the information through a registry would allow you to maximize the score in quality. Improvement activity as well. Our registry would handle all 3 categories that we have capability of. So, that's why you could use the APMA MIPS registry to submit your quality data. If you have the ability to capture that data in a templated format, we can incorporate it into our MIPS application, show you your scores, incorporate the improvement activity as well, and then be able to do submission.
Great. And let's see, we have two more. Wayne, I'll give you one and I'll answer the last one before we part. If we had a
Okay.
good first quarter of reportable activities, can we use the first 90 days?
Absolutely. That's why it's any continuous 90 days. It doesn't even have to be tied to the quarter. It could be, from April 15th to whatever 90 days, continuous 90 days. It used to be tied to quarters. They removed that requirement several years back. So yeah, pick your best quarter of performance and report on it. What we're talking about typically is COVID hit right around the March, April, May standpoint, and kind of knocked everybody on their backside. So that's why maybe that might not have been the best, but if it does happen, from your situation is different, go for it.
Well, thank you. And our last question is for those who are new in practice, where can we read about MIPS requirements? And you can visit APMA's website at apma.org/MIPS2020. And there are lots of resources there with the different categories and webinars and information about all of the categories, some shortened lists of recommended measures or activities from APMA. So you can check out that website and we can share that information in the email that comes to you tomorrow as well. And with that, we're getting close to the top of the hour, so I'll close us out this evening. I want to thank you all for joining us for tonight's webinar. As a reminder, all of the information related to the 2020 MIPS performance year, including information and links related to the MIPS COVID-19 hardship exception application, can be found at that website, www.apma.org/MIPS2020. Thank you all and have a great evening.
All right, thank you.
Thank